Hello everyone, my name is Judy Hoyt and I'm a recent graduate of the University of South Alabama's Nursing School. This research project was done in partial fulfillment of USA's Honors College curriculum with the help of my mentor, Dr. Carolyn Dolan. The CDC reports that more than 1 in 3 women and nearly 1 in 4 men experience sexual violence at some point in their lifetime. Additionally, about 1 in 4 women and 1 in 10 men have suffered some form of violent behaviors from an intimate partner. Sexual violence refers to sexual activity where consent is not freely given. Intimate partner violence refers to abuse or aggression that occurs in a close relationship and includes physical and sexual violence, stalking, and psychological aggression. For the purpose of conciseness, I will be referring to sexual violence and intimate partner violence simply as violence during this presentation. The health consequences of experiencing violence can be severe and long-lasting. These include mental, physical, sexual or reproductive, and behavioral health consequences. A few examples include injuries, insomnia, anxiety, depression, suicidal thoughts or behavior, phobias, PTSD, nightmares, substance abuse, withdrawal or isolation, difficulties with relationships, vaginal bleeding, unwanted pregnancy, STDs, miscarriages, and sexual dysfunction. Many of these consequences can turn into long-term issues for survivors. Long-term effects may include asthma, irritable bowel syndrome, headaches, chronic body pain, chronic pelvic pain or infection, and femicide and AIDS-related death. Additionally, sexual violence is connected to other forms of violence. For example, girls who have been sexually abused are more likely to experience additional sexual violence and other forms of violence and can be a victim of intimate partner violence in adulthood. Due to the numerous occurrences of violence, its severe health consequences on its victims, and the unpredictability of victim behavior, routine violence screening for every patient should be the standard in the clinical setting. To implement screening tools effectively, it is first necessary to determine healthcare providers' attitudes towards screenings. This research project looked at just that. What are healthcare providers' current attitudes towards violence screening tools? Could an educational intervention convince healthcare providers of the benefits of screening for violence? And could an educational intervention change healthcare providers' attitudes towards violence? The subjects of this study included healthcare providers at a faith-based clinic for uninsured adults in Mobile, Alabama, that has an average of 20,000 patient visits a year. All healthcare providers at the clinic who were willing to participate were included. This study is of quasi-experimental design, specifically pre-test, post-test. A pre-test survey was administered through Qualtrics by email. The survey evaluated healthcare providers' beliefs about their role in patients' health, their beliefs about mental and physical health consequences of abuse, their beliefs about the effectiveness of violence screening tools, their familiarity of screening tools, their prior use of screening tools, their thoughts regarding the benefits or harmfulness of administering tools, perceived barriers to implementing tools in the primary care setting, and how they would feel about integrating tools into their practice. 1 week after the pretest, a video presentation was sent to participants through a YouTube link by email. The video was a 12-minute long educational intervention presented by myself. It included statistics reflecting the prevalence of violence, the mental and physical consequences of violence, and how a patient who has been victimized might behave in the clinical setting. The video also included information about the screening tools that exist to identify these patients, the benefits of implementing the use of these tools in the clinical setting, and the barriers to screening patients, and a summary of trauma-informed principles of care. After the presentation, the participants completed another survey through Qualtrics by email to determine if their attitudes changed. The surveys contained 4 demographic questions, 18 Likert scale style questions, and 5 open-ended questions. To measure change appropriately, the same questions were asked in both the pre-test and post-test. The sample of convenience included 13 healthcare providers who agreed to participation. There were 8 physicians, 3 nurse practitioners, and 2 nurse practitioner students. Of those 13, 10 healthcare providers completed all elements of the study, and data were analyzed from their responses only. Participants believed it to be true that they have a role in improving patients' physical and mental health. They also believed it to be true that violence has negative mental and physical health consequences on its victims. Post-intervention, participants reported an expected increase in belief that administering screening tools could lead to an increase in identification of victims and an improvement in patients' mental and physical health. When discussing prior use of violence screening tools, the most used tool among participants was the HITS tool. When discussing the potential benefits of administering screening tools in the clinical setting, the most common answers were identifying victims, improving patient care, and improving patient health. When discussing the potential harm that administering tools could cause patients, participants listed reasons including it being uncomfortable or triggering, it putting victims at risk of danger, or it distracting from the visit. When discussing barriers of administering violence tools, the most common answer was time. When describing how they would feel about integrating screening tools into their practice, the majority of providers reported some level of willingness to use screening tools, and they showed even stronger conviction post-intervention. This study illustrated that an educational intervention about violence, its effects on victims, and current screening tools is effective in convincing healthcare providers of the benefits of screening tools. Future research is needed to determine how to best support healthcare providers in standardizing the use of violence screening tools in the clinical setting, and whether motivating healthcare providers to ask a simple question like, "Do you feel safe?" at a patient visit could significantly impact actual and potential victim safety.